Thanks, Ashley. Good evening, everyone. I feel quite humbled and honoured to be here speaking to you today, really. So I'm going to talk about sustainability, and over dinner I was just having some conversations with Christian, so he's asked me to add a couple of other nuggets in there as well, so I hope you'll find it interesting. So back in the summer of 2016, I was in Georgia delivering a training workshop in the very early days of the CDS training initiative. Through this speech, I'm going to talk about Dr. Z, modelled on the idea of Disease X. And Dr. Z represents a number of doctors that we've spoken to and liaised with across all of the countries. So I was in Georgia, and Dr. Z came over to me at the end of the workshop to shake my hand. And literally with tears in his eyes, he said to me, "Thank you. I'm so grateful that BMJ are here. We've been waiting and hoping for you. Until today, I've been using 20-year-old Russian textbooks to learn medicine and practice." And that's something I alluded to earlier. 2 years on, there are now 12,000 doctors across Georgia, Azerbaijan, Ukraine, Jordan, Iraq, and Vietnam who are using our resources as part of the initiative and hopefully making their countries a healthier place. And it gives me great pleasure, really, to talk to you today about how we got there and our vision for sustainability. At the heart of what BMJ do is our mission to improve healthcare outcomes globally. And although we're known as the British Medical Journal, we like to say that actually we're no longer just British. We work in over 80 countries now. We have offices across the Americas, India, and China, as well as in London. We're no longer simply medical. The whole range and breadth of healthcare professionals do use our resources. And we're no longer just a journal, as this initiative shows. So around 3 years ago, we began designing and developing the Clinical Decision Support Training Initiative and exploring our role in global health and global health security. And as the world emerged from 2008 and the economic crisis, we know that the issue of sustainability in global health became a central one. Although it's worth remembering, I think, that health financing isn't just an issue for low and middle income countries, it is also an issue for countries like the US and the UK. And that's all making sustainability a lot harder. So it's also become a key criteria for funders in global health and global health security, and that's something that we've had to grapple with as well as part of this programme. But I think you'll all recognise that it's broadly seen as a bit of a problematic and vague term. I think it's pretty inconsistently applied and interpreted on the ground, and we certainly struggled with what it meant for us in our programme. I know that there's been a lot of discourse about what is sustainability really and who is it actually for. And we've wondered, is it even fair or right to expect some of the countries that we're working with and some of the lowest income countries to sustain our programme? After all, we know it's far less likely that a low income country which doesn't even have electricity, sanitation and water and access to basic medicines, for them to be able to sustain a training and education programme. Than it is in a country that does have the basic medical infrastructure, education and training. So we wondered whether perhaps some level of dependence on aid from low-income countries is actually acceptable. And perhaps that should be recognised by some of the funders. Contrary to this, I came across the argument that aid is in fact harming some countries and hindering them from developing their own domestic financing and economic growth. And I have read that health financing has even been likened by some people to a crisis situation in which low and middle income countries depend on short-term external assistance and are failing thereby to develop a permanent sort of solution for their own financing. But at the heart of all of that, ultimately, is that we all want to do the best with the minimum resources available to deliver the greatest impact in partnership with the countries themselves. And we want to avoid short-term tick box projects which result in lots of ribbon cutting, but actually little long-term benefit to the countries, to their healthcare professionals, and ultimately to their populations. I visited a country in Africa in spring of 2017. And it was a bit of a tragedy, really, and extremely frustrating for me to see brand new aid-funded laboratories and hospitals that were sitting empty or underused because people hadn't thought about how they'd be operated, staffed, equipped, or maintained. And we feel that's where our programme comes in partly. At BMJ, we want to make sure that what we're doing has a meaningful and lasting impact. And I do believe that actually our programme is sustainable in some of the countries we're working in. We know that achieving that within a 3-year period, which is our current funding period, is challenging though. But we recognise that every country is different, structurally, culturally, politically. but we do think there's a common framework that can be applied to all. And we take a 5-pronged approach to sustainability, which relate to the materials that we provide and the content, making sure that doctors are able to use that content and access it, getting political buy-in and support, fostering the grassroots advocacy from the healthcare professionals themselves, and creating an enabling environment which is going to allow the resources to be used much longer term. Our hope is that if all of these are in place, and we can get these in place within the 3-year period, that we'll be able to make the case for domestic financing and that sustainment will follow thereon. So I'm going to talk briefly about each of those 5 areas, starting with the content. I said earlier that although our program's focused on infectious diseases, it's not in fact just about the infectious diseases. We know from our experience that ministries just won't support a program unless it also meets their own country level priorities. So we not only provide access to the infectious diseases content, but actually we cover 95% of the most commonly presented conditions in any country. We believe that this will mean greater effectiveness and improved healthcare outcomes overall, and that this will contribute to wider health system strengthening and resilience, and ultimately that will help a country respond to outbreaks and infectious diseases. So as such, global health security initiatives need to be considered, we think, in line with global health initiatives and vice versa. And we very much support the view of David Heyman and others who argue that individual and population security are 2 sides of the same coin, and that the aim of global health for universal health coverage, for example, also supports the achievement of the global health security goals. So it's great having the content, but it actually serves no purpose unless it's used, which brings me to pillar number 2, making sure that the doctors are capable of using the content we provide by translating it and making sure they can access it. So last year, I was in Azerbaijan, and again, came across Dr. X, and I was pretty taken aback and surprised to be told that Dr. Z, working in a remote area of Azerbaijan, was so keen to access BMJ best practice and BMJ learning to improve his own knowledge that he simply couldn't wait for us to translate the content into Azerbaijani and Russian. So every evening, he would sit with his grandchildren, who would verbally translate our materials for him from English into Azerbaijani, which sort of broke my heart a little bit. So when we design our products, and this is what I was talking to Christian about, we design our products and resources on the basis of extensive research around the world. We have something called a collaboration space, CoLab, which we've designed very much on the sort of same principles as Google. So what we do is we bring in doctors and healthcare professionals into a room, which is our CoLab, which has sofas, it has suites, it has whiteboards, it has specialist sort of facilitators and user experts and designers. And we bring them together to identify the problems that people are facing at the front line in whatever role they have and whatever it is they're doing. We identify that need by speaking to our users, and then we work out with our users how to solve that problem, and we implement that through our products, which is a really inspiring process to go through, which I've been part of. And that's ultimately what's led to the design of BMJ Best Practice and BMJ Learning. And we like to say that BMJ Best Practice is created by doctors for doctors, although that should now be by healthcare professionals for healthcare professionals. So we understand the difficulties that they're facing on the ground, and access is one of the main ones. So we make sure that we provide these materials to people both online, offline via a mobile app, and also as PDFs. We also know that doctors are very short of time, and we know that they want to make diagnoses and find a clinical answer to their question fast. So we make sure that through BMJ Best Practice they can do that in under a minute. And we know that the other thing that's really important for healthcare professionals and is a real big driver for sustainment is that they want to make sure they've got ways of meeting their fulfilling their requirements around ongoing professional education and development, CME and CPD. So we make sure that through using our resources, the way that we track their usage and track their learning on the actual products means that they can get credit not only for doing actual learning through the learning modules in their spare time, but also get credit for learning that they're achieving in practice while they're using BMJ Best Practice at the front line in front of patients. So access includes not only technology, but also language. And we're mindful that in most of the countries we're working in, English is not widely spoken. So we know there's little value in providing training materials that can't be used. So in the first 2 years of the programme, we've translated around 15 million words into 5 different languages. And that has basically secured the kind of engagement and adoption that we've managed to achieve. So number 3, getting political buy-in. The political and geopolitical dynamics of the countries we're working in aren't easy, and every country we've discovered has its own approvals and decision-making processes and preferred ways of working and communicating. For example, in Georgia, we initiated the programme, and within 3 months we were up and running. In Vietnam, it took us 18 months, half the project, to actually get the project started because of all the different approvals processes, which actually they weren't very forthcoming communicating at the beginning. And each step we went through, we discovered there was another step and another step and another step. But actually, once those approvals were obtained, we've then implemented the project with 3,000 doctors in the space of 2 or 3 months. So on top of that, the political stability of each country differs wildly. In one former Soviet Union country, the Ministry of Health changed 3 times in the space of, I think, 18 months. So as you can imagine, this has the potential to lead to delays or even the programme stalling completely. So we make sure that we're always recruiting specialists in country, and preferably nationals, who have not only the clinical, public health and education and training expertise, but also have the political know-how and understanding and can navigate the system effectively. And our governance structures for the programme are geared towards making sure that we involve ministries of health and national stakeholders from the outset, including medical associations and crediting bodies and universities as well. So we make sure that our sort of project charter, our memorandum of understanding, and all of our project governance is in place and agreed with the ministries and other stakeholders up front. We like to think that we work hand in glove with our country partners. And, I can't deny that that's not challenging. Sometimes we wish we didn't have to work through the Ministries of Health, quite frankly, but it is essential to sustainment. Number 4, fostering grassroots advocacy. So one of the reasons that we were approached to develop this initiative is because of BMJ's reputation for independence, integrity, and quality. Because people know that doctors and healthcare professionals trust us and want to work with us. And I think this was rightly seen as an essential factor to ensuring the sustainment of our programme and the success of our programme. Because I think we know what it is that motivates healthcare professionals. Dr. Zed in Ukraine said to us, Ukraine is going through a very difficult but interesting time right now. There are big reforms in medicine and we want to modernise healthcare. This is something I really want to be part of, as I want to improve the quality of care for my patients, and BMJ can help me reach my goals. So healthcare professionals want to do the best they can for their patients. They want to play their part in improving the healthcare outcomes in their country, whether that's around infectious diseases or non-communicable diseases or mental health or any other specialty. And also, they want to be exposed to the international community. So there is kind of self-interest and self-motivators there as well. They want to share what they're doing with others around the world, share their best practices, but they also want to contribute and add to the body of evidence and best practice developing out there. Without the support and engagement of local doctors in the country and without their appetite for evidence-based medicine, I don't believe we would have any chance of sustaining the programme anywhere, because why would a Ministry of Health or a healthcare institution financially support something that their doctors and healthcare professionals are disinterested in? So a critical part of our programme has focused on raising the profile and importance of evidence-based medicine itself as a principle, but also helping realise the value of our resources and the value that they have for individual doctors personally by tapping into what motivates them. And finally, also by demonstrating the impact that the programme is having and making sure that we're communicating and disseminating that as widely as possible and giving the doctors themselves to do that nationally, regionally and internationally through our sort of international conferences and by convening people together. So finally, creating an enabling environment. And I think actually this is where some of our most exciting successes have been. So what do we mean by this? What we mean is we want to embed our resources as far as possible within the medical and the teaching infrastructure of a country. So first we started by focusing on gaining the policy level support and commitment for accrediting BMJ and our resources so that they're recognised as valid sources of continuing medical education and professional development, because we know that this is a big driver for engagement with healthcare professionals who are much more likely to adopt the programme as a result. But we also know that it's a big driver for governments and for healthcare provider organisations who want to make sure that their doctors have a way of recertification and revalidation and a way of checking their performance. So in Azerbaijan, Georgia and Ukraine, we have been instrumental in achieving regulatory changes to implement a legal framework for CME and CPD in those countries. Secondly, we map medical school curricula against BMJ best practice and BMJ learning content so that the materials can be integrated into teaching practices. And this will help ensure that we're not focusing just on the current group of healthcare professionals and the current practicing doctors, but that a future healthcare workforce is also being appropriately trained and is already familiar with evidence-based medicine when entering into the profession. Going back to Dr. Zed one last time, this time she said, I regularly update the materials of my lectures with the latest information from BMJ and the CDS training initiative. I've shared information from BMJ with my colleagues and my students in training. She goes on to say, I would like to see this initiative grow to include more health professionals in universities. We need to work towards evidence-based international standards. By learning from foreign experience, we can identify improvements. I hope these small changes together will result in better standards of care and patient outcomes, both here and globally. We're working together, we're moving forwards together. So that sums up our 5 pillars of sustainability and the approach that we've taken. So what's next for us? It's been an utter privilege to be recognised by GCSP. Honestly, we're so humbled to be here today. But this is hopefully just the beginning. Over the next 5 years, we want to see the programme sustained in as many of the 6 countries as possible. We're also obviously implementing it in Kazakhstan, as Elisa mentioned earlier, and we hope to expand it to ever more countries. And now that we have the recognition of GCSP and that kind of quality stamp, I think that will help us as well. We also hope to cement BMJ's role in global health and global health security. And we feel that we can contribute first and foremost by building frontline capacity and capability, by convening the global community together to discuss, debate and share best practices and knowledge, through supporting improved research output in low and middle-income countries, and finally by disseminating that research and best practice. So I've spoken about some of the 12,000 doctors through my Dr. Z analogy who've benefited from the programme. It's only through these people that real long-term health improvement can be made. And our hope is that we can reach ever more healthcare professionals going forwards because, as we all know, infectious diseases know no boundaries. Thank you.